So last week we went live on Facebook talking about COVID-19. And well, let me stop and back up. I'm Janice Polk, here today with Dr. John Rothwell of Island Direct Primary Care. Hi, Dr. John. How are you this week?
Good morning, Janice. How are you?
It's afternoon. I've had so many technical difficulties today. I'm so sorry. You're lagging, huh?
No, you're fine.
Okay, good.
Welcome, everybody. This is live and this is real. So here is what you get.
That's right. That's right. We're just going to run on the fly. So I'm just going to jump right in and say I woke up this morning really feeling overwhelmed with the whole COVID-19 thing and all of the news reports that, Florida's the new hot spot. And I'm just like over it. I feel a little bit frantic about it. Not real bad. Like it's so hard still to know what to believe. And I don't like those numbers. And I really want to know what you think about it.
So what do I think about the numbers, or what do I think about the virus?
The whole, well, let me just say this. So last week when we talked, you did a really, really good job of kind of calming me down a little and putting it all in perspective. And I guess I'm looking, I think a lot of people are looking for that still, let's put this in perspective. What should we be doing? Like I have a friend who lives up in the Carolinas who reached out to me a couple of times and she said, we're scheduled to come down there for vacation. I don't know what to do. Should I come? Should I not? Should we stay home? She has 2 small children, young children. And I didn't know what to tell her. I mean, I don't know. I'm like 50-50 on it. What do we do?
Sure. You sound like the influenza vaccine, 50-50. And so we have some good years and we have some years that the prevalence of influenza is much greater than anticipated. And so when we look at SARS-CoV-2, or as the public knows, COVID-19, we're seeing a lot of different things in a lot of different areas right now. And I think what's interesting is in Florida, and including Brevard County, we're seeing some of the highest incidences of COVID-19 being reported compared to what was our previous reporter prevalence. And to kind of give you an example, prior to phase 1, we were looking at 1-2% of people tested having a positive PCR test, or the RNA test, and now we see our numbers jumping, and we're seeing increases of somewhere between 6 and 8%. Results of tests coming back positive. And does that mean that there's a second wave? I'm not a believer in the second wave.
No.
I believe we are in the same wave. And I think realistically, you have swells, if you will, if we're going to compare it to waves. And instead of having a choppy ocean, we have this, 10, 12, 15 second spaces between swells. And that's really based on how people are actually, going out into the community and what precautions they're taking out in the community. And so what's interesting is early on in the COVID-19 pandemic, areas like Washington State, New York City, Los Angeles, New Orleans, Louisiana, all of the testing was going to those locations. All the PCR tests from all the different manufacturers, they were all flooding to those areas, and they were testing tens and tens of thousands of people in those areas. We weren't. because we
Right.
didn't have the test available. And so,
I do remember that. I remember that distinctly.
yeah. And so now when you have organizations like Medfast Urgent Care, who, finally are getting deliverables of all their testing that they ordered, me at Island Direct Primary Care, at a time I had just under, 200 patients. I ordered enough tests and enough antibody screens for all my patients. And I'm sitting, I'm sitting good, but want to use them wisely because they're hard to come by. So if you use them too soon, then I'm gonna be out. And so I'm using those wisely. But organizations like Medfast, who have to kind of purchase in advance and prepare for a mass influx of testing, finally just getting the test. So we have and I say we because Island Direct Primary Care kind of does a lot of the background research for Medfast COVID task force. So we have thousands and thousands of capabilities of testing, actual diagnostic testing and antibody screening for members of our community. So we're seeing a dramatic increase where we were looking at maybe 200-300 visits in the early onset of the pandemic. People were staying home. Now we're looking at 500, 600, 700, 800 people a day coming into the urgent care facilities seeking either common illness treatment or actual, COVID-19 PCR testing or antibody screening. And even in my own practice, so this week, between last week and this week, I think I told you before, I took a little bit of a hit with the COVID-19. I had 185 patients. I had one small business basically fold, and so I lost all 25 of their patients because they all became unemployed, and but another 20 plus patients who were in the service industry, servers, bartenders, that kind of group, and I just kind of waived their fee. I'm like, look, you're going to need me if you get this, and so I'm still going to take care of you, but let's put you on hold, your payment on membership on hold for a couple months. So I'll just kind of give you credit, so it doesn't stack up on each other either. And I thought that was important. So I'm back now at about 175 patients. So I 16, 17, almost 20 new patients this month. And so I'm seeing that growth. But what's interesting is I've actually done antibody screening for 25, 26 patients in the past week. And I've done about 5 PCR testing. And so out of those, I've had one positive. So, and it makes sense because that one positive, he's in the service industry. And he, we went through phase 1 and now phase 2 for the state of Florida. And so it's a nightclub and lots of people, going out to dinner and walking around during the day with your mask on or taking whatever precautions you take is fine. But if you're young and you're single and you're going clubbing, you're not masking.
No. Okay, I want to ask you a question on that note. That's a great segue. So we're lagging. I hope we're not lagging too bad on Facebook. We are lagging. I know we are, and I'm going to work on that as we move forward because we do this every Wednesday. And we're going to get better and better at it. This is only our second time going live on Facebook, so hopefully we'll do better. But anyway, so I talked with a good friend this morning, and I was telling them that, I just feel kind of off, about all this, all the things I said to you when we started the call. And they made a really good point. And they said, okay, so, there are so let's say I go and I get tested and I'm positive. What does that really change? So, there are a lot of people who are tested who are positive, but their symptoms are really mild, or in some cases, they don't have any symptoms at all. And so, really, if you stop and think about it, it's what does it matter? If I went and got tested right now and I was positive, I'm not sick. So, what would it matter?
So one of the things that I ask myself, and one of the beauties of practicing utilizing the direct primary care model, is that we can actually go, if I do this test, is it going to change my plan of care? Because in the healthcare industry, there tends to be a lot of testing and a lot of billing and charging. And then when you do that, you can bring the patient back for another one, and another lot of billing and charging and copays and deductibles. And in my model, no copays, no deductibles, and we can decide together as strategic partners in health, if we do this test, will it change our plan of care? One of the things I like to ask is, how important is it? And so it's kind of like the influenza virus again, and I kind of backtrack in that because it's familiar to people. We may say there is 100,000 people test positive for influenza, but out of those 30 million uninsured people, how many of those people actually went out and got paid to have an influenza test, but yet they had the exact same symptoms? So with COVID-19, you're right. My patient who tested positive the other day, the fact that he tested positive, did it change anything? Nope, not from a treatment perspective.
How sick was he or she?
He had a cold, he had cough, he had a little bit of shortness of breath, but he's a vapor, and but he doesn't drink alcohol, he doesn't use recreational drugs. Vaping's kind of his thing, and lack of sleep, and but he just had this chest discomfort in kind of a shortness of breath thing, but he still had his taste and smell, and his cough wasn't any different than normal. And he kind of maybe a low-grade fever, though he was afebrile for me here. Many of the patients that I know of that were tested, very few of them most of them had mild symptoms, some of them had zero symptoms at all. And so you still want to observe them. But the importance of actually knowing if they're positive or not is because we are all our own individual. And so you want to kind of know where your ground zero is. So if the antibody screening, and this is very test specific, so the antibody screening that Island Direct Primary Care uses and MedFast Urgent Care uses, if you were exposed 3 to 5 days ago, the average person will start making IgM antibodies. There's acute phase antibodies. Some people might take 7 to 10 days, but on average, this test or this screen will detect if you were exposed within the 3 to 5 days and your body actually started producing antibodies. And the key question is, are you that person that's really resilient and you're not making any antibodies yet? Or are you that person who's just makes antibodies at, anytime someone sneezes on you? And so, so there is a margin of error there. We do that screening and say, okay, well, we know it was 3 to 5 days ago or later, and let's say up to 2 weeks if it's IgM, and up to however long, because the literature is still out for IgG. What we do know based off our test is that the IgM has been detectable up to 28 days later, and then around day 30, it's IgG only. So if it's IgG only, we could actually look back and say, who were you with 30 or more days ago that tested positive or who had symptoms? If it's IgM, we can say, who were you exposed to in the past 28 days, and those kind of things. So that's the important. So really from an epidemiology perspective, that and from a monitoring perspective, those numbers, those test positives, they're important to us as providers, as public health officials, as consumers of data, nerds, however you want to look at it. That's
Me.
Yeah, right. So, so for us, we just kind of want to kind of keep track. But, herd immunity is important. And so you want to test and test and test too to see, what that number looks like, because the more people that are exposed and the more people that start building immunity, the better.
Yeah. Yeah. Okay. So on the subject of testing, I'm glad you brought that up too. Last week, somebody commented on the live. We weren't able to look at the questions as we were talking, like we aren't today either. But maybe we'll do that. Be able to do that soon. I'm learning. I'm getting there. But anyway, somebody asked a question, and I don't remember the exact wording, but basically, I guess, are there two different types of tests? There's a swab test and there's something else. Is that right?
So there's.
He wanted to know which one was more accurate. That was the question. Is this test or this test,
Yeah.
more accurate? Which is a great question.
I think it's more about the specimen. So the tests are supposed to be molecular PCR testing. You guys don't need to know what PCR stands for, but COVID-19 it's an RNA virus versus a DNA virus, and so the testing actually looks at the RNA, and you have to have this RNA on your sample. And so there's numerous of ways to get this sample. And so you want a diagnostic test. So you want to look at the RNA. So that's why you hear me say antibody screen versus antibody test.
See, I didn't even notice that.
Yeah. So I say screen because I think the margin of error is too great, and the risk for false negatives and false positives kind of varies depending on testing. But when you get to the PCR testing, so actually looking at the RNA, you need the RNA to be on your sample. So how do you get that RNA? Nasopharyngeal, nasal, oral, saliva, sputum. So the testing facilities or the labs say, they prefer a nasopharyngeal, which is through the nose back to the pharynx. In other words, someone's basically sticking a swab in your nose and making you choke on it. That's how far back it goes. And so that means it's getting some of the mucous membrane and getting back to the pharynx, because what's your nose do? Your nose is a filter, right? Yeah. That's why we have nose hair.
Yeah.
And so it's a filter. So we're breathing in this whatever. And so whether it's the COVID-19 virus or any of the other coronaviruses, et cetera, we do a nasopharyngeal swab. If you just do a nasal swab, oftentimes you're not getting back far enough to where, the virus or bacteria or whatever maybe, be storing at. In the sense of the oropharyngeal, that's kind of like the, what's the next best thing or easiest sample to get. It's pretty good, but again, you have to kind of get that mucus, not just the saliva. So we're often, if you have tonsils, we're swabbing the tonsillars. We're kind of getting the back of the pharynx, which is the back of the throat. Not the top of the mouth and root of the mouth, but it's actually down towards the back of the throat. It makes you gag, right? That gag reflex. And so you want back that far. If you've had the virus for a little bit, probably the best sample is actually down in the lungs. And so when you're coughing up, unless you're getting sputum, you're really not getting that good a sample. So saliva test is kind of up in the air. And all of these are all about numbers. So it's like, the chances are, if you just spit in a cup and get saliva, then what is the false negative or false positive ability, capability with, or not capability, but false positive, false negative possibility in that sample, So your confidence intervals in the actual testing will vary, and so then that becomes a reliability or validity issue with the test. So, for me and in the organization that I'm partnered with Medfast, we do predominantly nasopharyngeal. If we're short the nasopharyngeal swabs, then we will do the oral pharyngeal swabs.
Okay, so let me ask you this question. I think a lot of people will be interested in the answer to this. I've told several people, and I know this, I was very, very sick in January and think that there's a chance that I had it. I had a lot of the symptoms. It surely lines up. So that was in January. Here we are, virtually July. If I was to, I've said several times, well, I'm going to get the antibody test. I'm going to get it. Maybe I will, maybe I won't. But I know we've talked about it. But so what would be the best way? One, what's the best way for me to get tested? And two, what's the probability that that test will be accurate at this stage? Anybody who was sick back in December, January, February, and thinks, oh my gosh, I had it. I want to go get the test. What should they do?
No, that's a great question. So for members of Island Direct Primary Care, all they have to do is schedule an office visit and we'll do the testing. So it's easy as that. And so the actual procedures and stuff like that doesn't cost the members anything. They just pay me for the test because I have to buy for the test, just like we would do a lab, right? So if you are not a member of Island Direct Primary Care, Medfast has access at all 12 of their clinics to do the antibody screening and the diagnostic testing. So my members get it, and they can get it Medfast. If you're uninsured, there's no co-pays, no deductibles. According to the CARES Act, you sign a waiver and you just pay for your visit. From that perspective. So everybody has access to being tested. To answer your question regarding the accuracy of the testing for antibodies for yourself, January versus June, and there's really no way to tell unless I test someone who tested positive in March and they were 30 days later IgG, and I have them come back again and I test them again and they're still IgG, and I know that they're, that's 4 months and 5 months, and then I can say, okay, what's the likelihood of, you being at 5 months? So unless we know someone who was positive and tested positive for IgG antibodies and then do it again, we really don't know. What we know from the literature is very limited based off SARS-CoV-2 because it's new, it's a novel coronavirus. If we look at SARS-CoV, which the structure's very similar to SARS-CoV-2, which is why this is SARS-CoV-2, there's some literature that reports that the IgG antibodies were detectable about 3 years into it. And so then the next thing we say is, well, is it detectable by doing a finger stick serology test, or is it only detectable by actually doing a blood draw and looking at that? So is there limitations in the technology being used to look at the actual antibodies to see if the antibodies are detectable? So don't know, accurate, don't know. Worth it, $25 for the test, 15 minutes of your time.
So just to be clear, this is a blood draw, not a.
It's a finger stick
all the way down my throat.
No. It's a finger stick, like if you were testing your blood sugar, if you were diabetic, it's a finger stick like that. Now LabCorp and Quest actually has blood draws, and we can do that, but then there's costs associated with that, right around $100 or so versus the $25.
All right, so here's the plan. So after we finish here, I'm going to make an appointment and I'm going to get that done. So what's the turnaround time? Will we have, if I do that relatively quickly, will we be able to have the results back that we can talk about it next Wednesday?
So why don't we do this?
Okay.
If you're going to spend the time and meet with me, let's do it live.
Oh, okay.
And we'll get the results while we're there.
Okay. All right. So you get the results like right then?
Yeah. So actually I do. It's like a pregnancy test.
Oh, geez.
So basically we'll put a little blood on a cartridge, and it takes about 10 minutes for it to hook up. So you and I always talk more than 10 minutes. So
always. We've been on for like 30 minutes now.
Yeah. So while we're chatting, the test will be running in the background. So I would be happy to do that.
Okay, cool. So, all right, that's a plan. Then I'll just plan to come to the office next Wednesday, and we'll shoot our live from there. That's exciting. Yay. Awesome. That makes me happy. Well, on that note, I think we're going to wrap up, and we've talked long enough. I've taken enough of your day. I appreciate it. Thank you for being patient with the technical difficulties, and I'm excited to see you next Wednesday.
That's great. Great. Well, thank you for having me. And if anybody's interested in learning more about myself or Island Direct Primary Care, they can find me at www.islanddirectprimarycare.com. Within the next couple of days, they can find me at www.islanddpc.com. So we're shortening that, so that's good.
That is, because I always stumble over it.
Yeah, exactly. So go to my website, and you can contact me there. There's a contact form, or for that matter, call me. My number is 321-392-6226. And I'd be happy to talk a little bit about the direct primary care model and how I believe it can be of value to you and your family or your business.
I think it's wonderful. It's a great model.